topic will be about experimental design and sample size estimation methods. And like I said, Prof. Kusi indicated earlier on, that usually in the estimation of sample size, we assume that independent of the research question, one research design must be applied, independent of the fact that you have different hypotheses to test. One sample size estimation method should be used, but that shouldn't be the case. Of course, the focus will be on experimental design, but you have overview of different study design. You have some motivating examples. I'll take you through designing an experimental study, a bit about cluster randomized design. We'll look at cross-factorial design, and then sample size estimation methods. Now, technically, we have 3 different types of study design. Experimental study design, that will be the focus of this lecture. Quasi-experimental study design, and then observational study designs. So in the context of quasi-experimental study design, you have your research question, and then your design is based on the fact that you have an intervention group, you have a control group, but there is no random assignment of the intervention. And usually this happens a lot when you want to assess impact of an intervention, impact of a program, policies. Okay, so there is what we call selection bias, where the implementers decide that they are going to give the intervention to these selected health facilities, for instance. They are going to give the intervention to these communities, for instance. So these communities, these health services are pre-selected. Now, because they are pre-selected, and for the fact that we're also thinking about trying to quantify the effect of that intervention on those outcomes, we think about trying to do what we call quasi-experimental study design. So in that case, you have to now select your controls or your comparison group, because the intervention site, depending on the kind of analysis that you want to do, more or less have been pre-selected. So we see in the context of quasi-experimental study design, you have the intervention, you have the control, but there is no random assignment of the intervention and the control. So there is pre-selection of what you call selection bias there. And then we have observational studies. For observational study design, we don't even have the control in the first place, or there is no comparison group. Okay, so you only observe at a material moment what is happening in the population. And based on what is happening in the population, you collect data, you analyze, and then you write your report. So you see, under observational study design, we have case control, we have prospective cohort study, and then there are cases where we have what we call the cross-sectional study design. So those 3 will fall under observational study design. So you see, there is no typical control, Okay, but the more rigorous study design is what you call experimental study design. The difference between the quasi and then the experimental study design has to do with the fact that for the experimental study design, you have the intervention, you have the comparison of the control group, but there is random assignment of the intervention. Okay. So in the context of experimental study design, it's a detailed research design and statistical methods that we use to collect data, where there is random assignment of the intervention, okay, into what we usually call the intervention or the control group. In the context of clinical trials, we call the treatment and then the placebo group, okay, depending on the fact that you're only dealing with 2 arms of the intervention. Now, if you look at the 3 designs, okay, it's only experimental study design that we impose a program, we impose a policy or a treatment group to the subject under consideration. For all the other study design, we don't do that. We only observe what is happening. In the context of quasi-experimental, because the intervention beneficiaries have been pre-selected, what we usually do is that you now go and select the control and make sure that the controls or the comparison group that you are selecting, they are similar as possible to the intervention group, so that if there is any difference in the outcome measure between the intervention and then the control, then you can attribute that difference, to the intervention that we implemented. So in the context of experimental study design, we are now imposing a program, we are imposing a policy or a treatment on a group of subjects, okay, that is of interest in terms of observing a change in their response outcome or in the response variable, or what people call the dependent variable or the outcome measure.
Prof, can you adjust your camera a bit? We are seeing almost at the top of your head. If you can just, yes.
Is it better?
Yes,
okay,
perfect.
Thank you.
Thank you.
Now, let's look at a typical motivating examples under experimental design. So you want to look at effect of therapy A and B on treating skin infection. So see, if you look at this research question, your outcome measure is skin infection. Now, the exposure of interest, okay, is the treatment therapy, which has two levels of the factor, treatment A and then treatment B. Now, we can use other study design to quantify the effect of treatment A or treatment B on treating skin infection. Different study design. It could be quasar, it could be observational study design. Okay. But then the challenge here is you have an exposure, okay, that is the treatment therapy. And you want to see how the treatment therapy, okay, affects or causes a change in the treatment of skin infection. Remember that apart from the treatment therapy A and B, there are several other factors that could contribute to the change in skin infection, or to the intensity of the infection. You understand? What experimental study design is going to do is trying to balance out all observed and unobserved factors that could also influence skin infection, so that if we see a change in skin infection, then we can now attribute the change to the differences in the therapy under consideration. So in this case, therapy A and then therapy B. Now, there are cases where you want to, for instance, quantify the effect of surgery, chemotherapy, radiotherapy, or combinations of these treatments on time to death of certain cancer patients. So we want to evaluate this. But we know that, the outcome measure in this study is time to death. Apart from the treatment therapies that I have highlighted, surgery, chemotherapy, radiotherapy, or the combination of these different interventions, age, for instance, is a typical confounder because age can have effect on the acceptance of these interventions, and they can also have effect on time to death of any ovarian cancer patient. Okay, so in as much as we are interested in trying to quantify the effect of the exposure, which in this case has to do with surgery, chemotherapy, radiotherapy, or the combination of these different treatments, age is a confounder because age is going to have effect on the acceptance of these different treatment therapies or on the time to death of these outcomes. In other words, if you run any analysis and you don't control for age, then your results will be biased. In the context of experimental study design, if it's well conducted, okay, the age distribution among those who went for surgery, chemotherapy, radiotherapy, and all that's supposed to cancel out. So if I say supposed to cancel out in the context of statistics, we are saying that the average age for surgery, chemotherapy, radiotherapy, or combination of these treatments among the patients that were enrolled, okay, should be same. In other words, there shouldn't be any statistical significant difference in the distribution of the ages among the different treatment therapies. In that case, then you are taking out or you are isolating the effect of age, okay, on time to death. And one way to achieve that is when you do what you call, or when you conduct an experimental study, because through the random assignment of the different treatment therapies, the age distribution, in terms of the mean age distribution of these outcome measures vis-a-vis the exposures under consideration will be cancelled out. Okay. Now, you can also have another typical example of experimental study where you want to look at impact of, say, claims IT on health cost savings. For instance, National Health Insurance Authority decided that, okay, they want to implement an intervention. That intervention is what you call claims IT. So some health facilities will be given that intervention, which is the claims IT. So they will use a digital version format to submit their claims. And then other health facilities will not get that. And they want to see how the implementation of the claims IT is going to help reduce cost. Now, You see here, the intervention is being implemented at the facility level. So we say that the intervention is creating what we call clusters. In that case, you see, we are not doing the randomization at the individual level. We are now doing the randomization at the facility level. And that is what usually we call the cluster randomized design. I'll be going into detail on that. So if NHIs want to do that, the first thing is that they need a sampling frame of all the health facilities. Do your sample size calculation. Let's assume that you've done your sample size calculation or power analysis, power calculation, and then your final sample size is, say, 200. Then they do what you call random assignments. Okay, so you randomly assign some health facilities to benefit from the claims IT, and then the other health facilities will not benefit from the claims IT. By doing these random assignments, okay, you are trying to ensure what you call internal validity. So you see, in this case, internal validity is trying to isolate all other external factors that could also have effects on health costs, So if you do the random assignment, then the difference in the mean health cost expenditure between facilities that benefited from the claims IT and those that did not benefit from the claims IT now becomes the true impact estimate of the claims IT. So what experimental study design will do in this case is making sure that the characteristics, okay, or the statistical similarities between facilities that benefited from claims IT and those that did not, they are virtually the same. Virtually the same here is that there is no statistical significant difference in the characteristics of the two different groups. Okay. Somebody can also do a study. The person wants to see how different exercise regimen would influence weight loss. Okay. So once you have the list of the patients, okay, then what you do is that you randomize them into Tai Chi, Judo, Kung Fu, and then you now measure weight loss on the outcome. By doing experimental study design, you are trying to eliminate all other factors that can also contribute to weight loss, So once you do this and you see any change in weight loss, then you can attribute the change in weight loss to the effect of the different treatment regimen, which is here in this case, the Tai Chi, the Judo, the Kung Fu, and then all these other different treatment regimen. It can have impact of vaccination on disease outcomes. Okay, so in the context of clinical trials, where you want to examine the effectiveness of vaccination on a certain disease outcome, we do what you call randomized control trials. In the context of randomized control trials, you have human subjects. So you randomly assign these human subjects into those that will benefit from the vaccination and those that will not get the vaccination, but rather get the placebo. Okay, so we have some examples of how and some specific research questions on experimental study design. Now, why experimental design? Why not quasi? Why not observational study? We do experimental study design because, one, we want to establish cause-effect relationship between the exposure of interest, if it's treatment, and then the outcome measure of interest. Why? So you can only establish causal relationship when you are in the position to eliminate all other extraneous factors that will influence your outcome measure of interest. And that is the essence of we doing experimental study. Okay, so experimental study basically will ensure that there is no systematic difference between the project beneficiaries or between the intervention group and then the control group at the start of the study. There will be no difference at all. Okay, the other thing that experimental study design is going to do is to remove sources of bias. One is what you call self-selection bias. Remember that you can only offer an intervention, but the take-up is voluntary. You cannot force anybody to take up the intervention. So if you say that you have, for instance, health insurance, people that so voluntarily come to take up the health insurance may be people who are sick. So if you just compare those that pick up the intervention against those that did not pick up the intervention, and you look at the changes in the outcome measure of interest, you end up saying that, oh, those that benefited from the health insurance did not see improvement in their health outcome. When in actual fact, because you can offer the intervention, then the take-up is not voluntary. The people that went for the health insurance are technically sick, and then they have been having higher frequency of hospitalization. So because of that, they decided to offer for the health insurance because they know that they've been visiting the health facilities at a higher frequency rate. So right from day one, there is a systematic difference between those that went in for the intervention and those that decide that, well, we are not going for the intervention. Because somebody will tell you that for the past 6-7 years, I have never been sick, so I will not go for the intervention. Another person is going for the health insurance because this person has been visiting the hospital for a number of times within a year. So from day one, from the start of the study, you see a clear difference, a clear systematic difference in terms of the health outcomes between the two groups. But of course, if you do experimental study, what you are trying to avoid is the fact that you wouldn't get these issues of what you call self-selection bias. So you cannot self-select yourself to benefit from the intervention. You can only benefit from the intervention when we apply pseudo-random algorithm. And then you are lucky that the algorithm randomly selected you to be part of the study. In that case, you are avoiding self-selection. And then we have what you call agency selection. People decide that I'm going to give the intervention to these communities because they vote for me. I'm a parliamentarian. They vote for me. That is why I get my maximum number of votes. So the person decides that community A, B, C, and D will benefit from the intervention. The other communities will not benefit. In the context of experimental study design, you avoid that. You avoid that because you have a random draw of all the communities. Okay, once you do your sample size estimation, you know the total number of communities that you're supposed to study. You get these communities, then you do what you call random assignment of the communities into intervention and control. So there is no way that agency, that individual will decide who benefit from the intervention and who does not benefit from the intervention. And then we also say that experimental study design is the gold standard for constructing counterfactual. What do we mean by counterfactual? What will have happened in the absence of the intervention? You know, in the context of any evaluation, okay, what we know is the fact that for those that benefited from the intervention, we can easily determine the outcome measure, okay? But what we do not know is what will have happened in the absence of the intervention, and that is what we call the counterfactual. The essence of experimental design fundamentally is to help us construct what we call a valid counterfactual. A valid counterfactual in this case means that a comparison group that is as similar as possible to the intervention group, so that if you see any change in the outcome, then that change can be attributed to the fact that one group benefited from the intervention, then the other group did not. Okay. Now, when you want to design experimental study, technically, we are only looking at two steps, technically. Okay. So one, we have a sample of potential participants from a relevant population. So you see, let's assume that I want to give an intervention to people who are suffering from, say, ovarian cancer. And I have 2,000 patients, okay, coming to a facility and they are all suffering from ovarian cancer. So that becomes my target population. One, because they are eligible. They are eligible because I indicated earlier on that you have to have ovarian cancer before you can benefit from the intervention. Okay, so all these guys are all eligible, and they are 2,000. Okay, but I cannot study all the 2,000. So I do my power analysis, and then the power analysis is telling me that out of the 2,000, just study only 400. So from the 2,000, I do what we call random selection of the 2,000. Okay, random selection of 400 from the 2,000. That becomes what you call the evaluation sample. So see, I'm getting my evaluation sample from the eligible population or from the target population. Now I get my evaluation sample. Because that was through random selection, that 400 we say is representative of that target population. In other words, the characteristics of the individuals in the 400 will be similar to the characteristics of individuals in the 2,000 population size. Okay, so that is the first stage. And then the second stage, after getting the 400, I know that some must benefit from the intervention and others will not benefit from the intervention. So from the 400, what do? I do what we call random assignment. So this is the difference. First is the random selection. Okay, 400 from the target population of 200. Now, the second one is what we term as the random assignment. So now I know my sample size, 400. I want to do random assignment. 200 will benefit from the intervention. 200 will not benefit from the intervention. So technically, these are just the two stages in terms of we doing experimental study design, but you'll be seeing the variability in terms of the different study design as we go on. Now, I indicated that one of the reasons why we do experimental study design is the fact that we want to generate what we call a valid counterfactual. So you see, once you conduct or once you use experimental study design to address a research question, then you are technically what you are saying is that both observed and unobserved factors, the effect of both the observed and then the unobserved factors will cancel out. Okay, because if I say unobserved factors, there are some factors that you cannot measure. You cannot use a data collection instrument to measure. Okay, so once you design a data collection instrument, all the factors that can also influence your outcome measure, but you are not in the position to measure, will be captured as unobserved factors. Observed factors are factors that you can measure with your data collection instrument. In that case, when you are fitting your regression model, you are in the position to adjust for those variables. Okay, so let's assume that you have an unobserved factor, and this unobserved factor has effect on your outcome measure of interest. Okay, you are not able to measure these factors, but with the help of experimental study design, once you do random assignment of the individuals into intervention and then the control, then there will be no systematic difference between the intervention and the control relative to the unobserved and even the observed factors. So that once you see any change in the outcome, then that change can be attributed to your intervention. So if you look at this, you have population of eligible units, you do random selection to preserve the characteristics of that target population, you have your evaluation sample. You do random assignment of your evaluation sample into treatment group, okay, those that are assigned to the treatment and then to the comparison group. So technically, these are the two main steps that we use in terms of experimental study design. Now, how does randomization ensure that your treatment, the characteristics of the treatment is the same as the control? Okay, now we must take note that a single randomized trial may not eliminate all biases between the treatment and the control. So there are cases where, especially when you have a very small sample size, so there are cases where there is a statistical significant difference, for instance, in the mean age between the intervention and then the control group. Huge difference, you know, and then you see that your p-value is statistically significant. In that case, yes, you did randomization, but you did not achieve 100%, you know, in terms of the similarity index for the observed variables between the control and then the intervention group. Okay, but with enough sample size, and that is the other part of the lecture, okay, what you are trying to do is to increase the probability that there will be no systematic difference between the intervention and then the control relative to both the observed and then the unobserved factors. Okay, now we also have what we call cluster randomized design. Okay, in the context, you know, there are two types of experimental design. I mean, the types in terms of the design. Okay, you can do individual level randomization, and then you can also do what you call cluster level randomization. It depends on the level at which you are implementing the intervention. There are some interventions that are implemented at the individual level, especially when you are doing clinical trials, and then you have vaccines. So you give the vaccine to an individual. So you call it individual level clinical trials. Okay, so it's at the individual level. But there are some interventions that you cannot implement at the individual level. You have to implement the intervention at the cluster level. So in this case, cluster could be health facility, cluster could be community, cluster could be school, cluster could be region, cluster could be district, cluster could be anything. So you see here, the intervention is implemented at the cluster level. In other words, we say that our intervention is creating what we call clusters. So you implement the intervention at the cluster level, but individuals within the cluster will benefit from the intervention. For instance, you have an intervention, you are implementing the intervention at the household. So let's assume that this intervention is the distribution of iodinated salt. So when you are distributing iodinated salt, you give the iodinated salt to the household. So you are implementing the intervention at the household because every other individual who live in that particular household will benefit from that iodinated salt. So see here, we are saying that your intervention is creating clusters. Now, in the context of cluster randomized design, your sample size estimation is different. So your sample size this time is not the number, it's just not the number of individuals. It's rather the number of clusters. You understand? So you first estimate the number of clusters, which is the number of schools, the number of households, the number of health facilities, and all that, before you determine the number of individuals that you need to get from these clusters. So the focus in terms of cluster randomized design has to do with determining the number of clusters, not just the number of individuals. So you determine the number of, because the larger the number of clusters, the better, in the context of randomized design. So we also have cluster randomized design. Why do we usually do cluster? Because one, there are some interventions, there are some policies, there are some programs that can only be implemented at that level. You cannot give the intervention to an individual. If you give a community a pipe-borne water, a borehole, for instance, that borehole is implemented at the community level, and you have all individuals going in there to fetch water. So that intervention is at the community level. Okay. And then there are some other ethical considerations. The same thing applies. You are implementing or you are putting boreholes there to reduce the prevalence of, say, diarrhea in a certain community. For ethical consideration, you cannot decide that you are going to give the borehole to just one household. So the borehole is strategically placed such that every other person, every other member in the community will have an equal probability of accessing that particular borehole. So for ethical consideration, you cannot do that. And then the other thing is, it avoids what you call treatment group contamination. Remember that if you are trying to develop a study using experimental study design, one thing that you want to avoid is the fact that the control should not benefit from the intervention that you are implementing. In other words, the control should also not benefit from a similar intervention that is also implemented to cause a change in the same outcome, So if you want to do something like that, for instance, in the case of the distribution of the iodated salt, if I'm doing individual level randomization, then it becomes very easy because it's at the individual level. I can do the random assignment and you can have two people living in the same household. One is intervention, the other one is control. Now, let's assume that the mother is in the intervention group and then the child is in the control, meaning that the child is not supposed to benefit from the iodated salt, but it's the mother that cooks. You understand? So the mother will cook and then the child will benefit from the iodated salt. In other words, the child that has been classified as being in the comparison or control group is now benefiting from the intervention. So you run your estimate and you come out that, the intervention is not working. It's not that the intervention is not working because there is a spillover effect, there is contamination. And that is why you are seeing that. But if you do it at the cluster level, if you implement the intervention at the cluster level, then it becomes extremely difficult for you to have issues with spillover and then even contamination, because if it's at the household level, then it means that household A will benefit from the distribution of the iodated salt, but household B will not benefit from the distribution of the iodated salt. Okay. Then we also have unit of randomization versus unit of analysis. Of course, I said that your unit of randomization can be at the cluster level, and that is when we have cluster randomized design. But your unit of analysis may be at the individual level. Okay, for instance, you implement an intervention at the facility level, but your unit of analysis are patients who are visiting these facilities. That is your unit of analysis. But there are also cases where your unit of analysis is the same as the unit of randomization. For instance, you implement an intervention at the facility level, and then you also assess the effect of that intervention also at the facility level. In that case, your unit of analysis is the same as your unit of randomization. Now, there are different methods of randomization. The first one, I'll just take you through this: oversubscription, randomized phasing, within group randomization, and then randomized encouragement design. Different forms of randomization. What is oversubscription? Okay, you have an eligible population of, say, 2,000, and then they are all suffering from ovarian cancer. Okay. Technically, they are all supposed to benefit from the intervention, but you can only give the intervention to only 100 patients suffering from ovarian cancer. So there is oversubscription of the intervention. Okay. And this is where experimental design can help. So because of the oversubscription, you can only give the intervention to, say, 50 of them. So what do? you do random selection of 100 from the 2,000, and then you do random assignment, the 50-50. So the 50 will benefit from the intervention, then the 50 will serve as your control, your comparison group. That is oversubscription. Okay. Then we have randomized phased in. Okay. Now, in the context of experimental design, okay, there are cases where you want to give the intervention to all the 2,000 ovarian cancer patients. But looking at the resources, okay, you cannot give all of them. But the plan is to give all the intervention to all the 2,000 ovarian cancer patients. So what do? You can adopt what we call randomized phasing. Okay. So your 2,000, you say that, okay, because the budget can cover year one, 500 ovarian cancer patients, the first thing that I will do is that I'll randomly sample 500. Okay. And then that 500, I'll give them the intervention from year one. So all the 1,500 will serve as your control group. Then in year two, you randomly sample 500 from the remaining 1,500. So the remaining 1,000 will now serve as your control. Year three, you randomly sample 500 from the 1,000. So the remaining 500 becomes your comparison group. And then in year four, everybody benefits from the intervention. Okay, that is what we call randomized phasing. And then we also have within group randomization, what people call randomized block design, within group. Let's assume that there is an exposure of interest. That exposure is age. You know that age can have effect on the acceptance of your treatment. And then the same age can have effects on your outcome measure of interest. Let's assume that your outcome measure of interest is death. Okay, we know that age can have significant effect of death. Okay, age can have significant effect on death. And then your intervention is also going to improve the survival time of these patients. But you are cognizant of the fact that the variable age is a confounder, okay? Because the probability that somebody age 60 plus will die is higher than the probability that somebody age below 60 will die, okay? And you want to use what you call within group randomization. So what you do is that you can easily divide or stratify, okay, your sampling by the age distribution. Okay, you can do that. You stratify by the age distribution. So greater than 60 years, below 60 years. So the greater than 60 years, you do random assignment of the intervention to control treatment. So within the greater than or equal to 60 years, you have control intervention. Then below 60 years, you also have control intervention. Okay, that is what we call within group randomization. Okay, and then we also have what you call randomized encouragement design. There are cases where government decides to implement an intervention. So the government says, I'm going to give the intervention to everybody. So the intervention has been offered, so it's there. Once you want to take it, you take it. A typical example is the first senior high school. The government of Ghana decided that, I'll give the intervention to everybody. In that case, you will not even have a comparison group. There is no way you can do random assignment of the intervention because the intervention has been offered to everybody. What you can do is what you call randomized encouragement design. Okay, you bring an encouragement so that people will go in for the intervention. So you have a group of people that will receive that encouragement, and then the others will not receive. Okay, so those that will receive the encouragement, we expect that most of them will take up the intervention compared to those that will not receive the encouragement. In that case, you are now comparing two groups. Those that received the encouragement and went in for the intervention and those that did not receive, we compare the outcomes. Okay, usually we call this the local average treatment effect because it's not technically not like you are evaluating the impact of the intervention, but you are saying that the more people pick up the intervention, this is the change that you see in the outcome measure of interest. And that is what we call randomized encouragement design. Okay. Now we also have what you call cross-cutting or factorial design. Now, in the context of cross-cutting or factorial design, this is what we mean. Usually, you see that in experimental studies, you have the intervention and then the control. You have intervention A, and then you have intervention B. But there are cases where you have more than two groups or two levels of the factor. So you have intervention A, you have intervention B, and then you have intervention A plus B. So that is cross-cutting or factorial design. And it has implication on the estimation of the sample size. So we are also saying that it's not always the cases that in experimental studies that you have two groups. No, you can have more than two groups. So you have patient on intervention A, patients on intervention B, patients on intervention A plus B, and patients who are not on any intervention. So that is what we call cross-cutting or factorial design. And like I said, it also has implication on sample size, because once you are using cross-cutting or factorial design, your sample size will increase. Okay, so if you have about 4 different levels of the intervention or 4 different interventions, okay, and you want to evaluate it using experimental study design, then of course your sample size could be multiplied by a factor of say 4, okay, relative to if you have used only 2 levels or 2 different treatment categories. Okay, now let's look at some threats to experimental study design. The first one is what you call Hawthorne effect, and then I'll call this together, Hawthorne effect, and then what we also call the John Henry effect. So what is Hawthorne effect? Once people realize that you are giving them an intervention, then they change their behavior. So it's not that the intervention is causing the change, but because they know that you are giving them the intervention, they've changed their behavior, and then the behavior is causing a change in the outcome. That is what we call the Hawthorne effect. Okay, and then we have what we call the John Henry effect. The John Henry effect, somebody has realized that you did not give him or her the intervention. For instance, you are distributing BedNet. Okay, this is a cluster randomized control trial. So some households benefited from the BedNet, other households did not benefit from the BedNet. Now, because it's cluster randomization, the other households, okay, got to know that, oh, my neighbor got the BedNet, I did not. And then the person decided that, well, you, the researchers, we're going to prove to you that we are not poor. So those that are in the comparison group, they decided to buy their own BedNet. So they are also sleeping under BedNet. But during your analysis, you are assuming that they never benefited from the distribution of the BedNet. That is what we call the John Henry effect. When the people in that category decide that they did not benefit from the intervention, but they will get the intervention by whatever means. Okay, in that case, if you are estimating the impact of your intervention and you are not careful, your estimate will be biased. But I'm not going into detail because there are 2 ways to even generate that estimate. Either you are using intention to treat or treatment on the treated estimate to cater for that as well. Another thing about experimental study design, at the beginning of the lecture, I made mention of the fact that it's the most rigorous design. Why? Because it will make sure that there is no systematic difference between observed and unobserved factors. But because of ethics, we've not been able to establish that smoking causes lung cancer, for instance. Why? The best way to establish that is to use experimental study design. So you have patients who are disease-free, they don't have any lung cancer. Then you do random assignment of the patient into those that will smoke and those that will not smoke. Once you get those that will smoke, then you distribute the cigarettes to them and tell them to smoke for, say, 6 years. And then you'll be following them to measure the incidence of lung cancer compared to those that will not smoke. That is unethical. So you can't do a study like that. Okay. So because of ethical issues, there are cases where we want to establish cause-effect relationship between variables, but you're unable to do that. The other one has to do with external validity. Of course, in clinical trials, you have a few patients who decided that they'll be part of the study. And then you did the random assignment of these individuals into intervention and then the control. Of course, within that clinical setting, okay, where everything is well controlled, you may see significant effect of the intervention on the outcome measure of interest, but in real life, you may not have that. The other one has to do with compliance. Yes, you can offer an intervention, like I said, but the take-up is voluntary. So people may not take up the intervention. So you see that the sample size in the intervention group can reduce, and that will affect the power of the study. The other one is spillover effect. When you have effect of the intervention affecting the comparison group, it can also bias your estimate. The other one is contamination. Spillover effect is just a subset of contamination. So you see, for contamination, you can have a different intervention, an intervention that you are not the one implementing, but that intervention has effect on your outcome measure of interest. That is when you have contamination. Remember, the spillover effect is the effect that is coming from your intervention and spilling off to the control group. The other critical issue is attrition. In experimental study design, usually this is prospective cohorts. Okay, we follow them up in time. So there is the possibility that people will attrit, okay, meaning that there will be loss to follow up. And in fact, if it's even random attrition, you may not have a lot of problems in terms of estimating the effect size. Because in random attrition, the characteristics of those that are treating the intervention group is the same as the characteristics of those that are treating the control group. But it becomes a bit problematic when you have selective attrition. Selective attrition here means that the characteristics of people living the intervention group is different from the characteristics of people living in the control group. So in your end line estimation, you are comparing two different people. They are no longer the same in terms of the observed and even the unobserved factors. A typical example of selective attrition is this. You implemented an intervention to improve the socioeconomic status, okay, using experimental study design, to improve socioeconomic status of people living below poverty lines in rural communities. Now, you said that this intervention will be implemented for 2 years, and then after 2 years, you go to the community to do your end-line survey. So the cluster randomization was done at the rural community level. So some rural communities benefited from your intervention, others did not. But during your end line, you realize that all those that benefited from the intervention and the intervention truly made a positive impact on them, okay, they all left the village and relocated to the city because they've made money. You still want them to live in the city to live in the village for additional 2 years. So see here, those that are leaving the intervention group are those that actually benefited from the intervention and then they are leaving the system. Then we also have what we call heterogeneity in the impact estimate. Remember, impact of an intervention on males may be entirely different from the impact of the same intervention on females. That is heterogeneity, differences in the impact estimate based on another variable with more than 2 or 3 levels of the factor. Okay, so we are saying that the impact of an intervention X on an outcome Y will not be the same among the elderly compared to the adolescents. That is what we call heterogeneity of impact. And in experimental study design, you have to take care of that. The other thing is what you call instrumentation effect, you know, and people make some serious mistakes when it comes to designing experimental study. Instrumentation. At baseline, I decided to ask a very specific question. Have you ever been diagnosed with hypertension? At baseline, then some will say yes, no. So you see, the response there has only 2 levels of the factor. But during end line, I asked the patient to tell me they are carrying systolic BP. So you see, they are not the same question, even though they are trying to measure the same outcome. So instrumentation, okay. So we are saying that the data collection instrument that you use to measure these outcomes at baseline, make sure that you use the same data collection instrument to measure the outcomes at end line. And then testing effect. You design an intervention to improve, for instance, health-related quality of life. So as part of this intervention, we're training them on nutrition, diet, and all that, and how to improve that. So you gave them some questions, knowledge-based questions on nutrition and food security, for instance. And then during the end line, you give them the same questions. It means that your intervention may not improve their knowledge score in food, in nutrition and food security. It's because they've seen the question before, and for some reason, they know the answers. So after your training, they will score. You know, their knowledge score will increase after your training, after your intervention. Not because the intervention is working. It's because of what we call the testing effect. They know the answers. Okay, so if they are not even attended the training, which is your intervention, they could have still gotten the scores that they were looking for. Okay, and then finally, we have what we call multiple outcomes. You have an experimental study and you have a lot of outcomes. So you have one intervention and you want to quantify the effect of the intervention on several outcomes. It's also a threat to experimental study design because of spurious hypothesis testing, spurious correlation between the intervention and these outcome measures of interest. So the more you are testing hypotheses, then the likelihood of you having a spurious relationship or correlation between the intervention and then the outcome measure of interest. So if you have about 10 hypotheses to test, it could be that the intervention has no effect on any of the outcomes. But because of multiple hypothesis testing, because you have multiple outcomes, okay, you end up saying that, oh, the intervention caused a change in one of the outcomes, when in actual fact, it's because you are doing multiple testing. And one of the ways to correct for that is when you use the Bonferroni correction. So instead of comparing, okay, the p-values to your alpha, the probability of you committing type 1 error, usually around 0.05. Okay, so if you have 3 core outcomes, then you have to divide your alpha by, say, 3, and now compare your p-values to the Bonferroni correction factor, which is alpha over 3. So we also have issues with multiple outcomes. Now, sample size estimation. Yes, when I started, I indicated that in the context of experimental studies, there are 2 key things, okay? The first one is random selection of the individuals from the eligible population, and then the random assignment. So if you have an eligible population of, say, 2,000, the first thing is you have to do random selection from the 2,000. Now, the question is, how do you know the number that you first randomly select using pseudo-random number generator? It's difficult. And that is where power analysis, power calculations will come in. Okay. Because we want that number. So we have power calculation. Power calculation technically is when you apply these statistical formulas, based on the outcome measure, based on the study design, and then you estimate your sample size. And then we have power analysis. Power analysis is more decision conflict in some of the communities that you want to visit. We cannot go to these communities, So in that case, we have to do what we call power analysis. So power analysis is more or less a decision-making process about the sample size, given the real-world constraints and what we are facing in real world. But power calculation is purely based on the mathematical formula, and then we'll be going through. Okay. Why do we do sample size estimation? One is to avoid collecting too much information. Okay. And that will be very expensive to do. And then the other thing is to avoid collecting too few, because then your study will be underpowered. Now, once your study is underpowered, if there is even a significant effect of the intervention on the outcome measure of interest, your study design will not be in the position to see that effect. And that is the more reason why we do power analysis and then the power calculation. One. So what are the key issues that you have to consider in the estimation of sample size per experiment? The first one is type 1 error. Okay, rejecting our null hypothesis when the natural fact is true. Type 1 error, critical. We need to understand that. Then the other one is minimum detectable effect. What change do we think or do we want to see to make statistical significance or clinical relevance? So there's a difference between statistical significance and then clinical relevance. So what change do we want to see? Okay, that is the minimum detectable effect. Then we have the power of the study. The ability of your study design to see a significant effect of the intervention if it actually exists. That is the power of the study. We also need that if you are estimating sample size. And then the type of outcome measure. Are we dealing with a continuous outcome like systolic BP? Are we dealing with a binary outcome like, say, death, whether you die or you survived? Okay, are we dealing with a time to an event outcome? Okay, so time to reoccurrence of ovarian cancer, time to rearrest of, say, prisoners, time to developing a new condition, a new disease outcome, whatever. So if it's a time to event outcome, okay, which is based on the hazard ratio, your estimation of sample size will be entirely different. If you're estimating sample size and then your outcome is quantitative continuous, okay, the statistical method will be different. If you're estimating your sample size and then you are looking at a binary outcome, your approach, the methods that you use to estimate the sample size will be different. Okay. And then the other thing is the intervention creating clusters. Okay, so if you are going to implement the intervention at the facility level, then it means that your intervention is creating clusters. In that case, you have to think about the design effect. You understand? So the design effect basically is just 1 plus the intra-cluster correlation coefficient, the average cluster size minus 1. Why are we doing that? So the average cluster size here will be the average number of patients per facility. Then we use that because you have to adjust your sample size by the design effect for the mere fact that your intervention is creating clusters. And then the last one is the study design and then the objectives of the study. Usually, and Prof, you rightly mentioned that even when people are doing a different study and they are comparing 2 groups, you see that they are using sample size estimation techniques for, let's say, estimating prevalence or incidence of a disease. So the study design and then the objectives of the study. If your study is cross-sectional and you are not doing any comparative analysis, but you are only estimating. So you see in statistics, we have estimation and then hypothesis testing. So if my research question is, what is the prevalence of hypertension in the community? So you see here, the study objective is only asking about estimation, not hypothesis testing. So it will reflect in the estimation of the sample size. Okay. But if I'm doing a study and I want to compare the mean systolic BP between those in the intervention group and those in the control group, and then because here I'm doing a comparative study, okay, the estimation of the sample size will also be different. You understand? But there are cases where in one study, you have the two objectives. Okay, one is estimating incidence. The other one is doing comparative analysis between the intervention group and then the control group. What do you do? Then it means that you have to estimate one, the sample size when you are only doing estimation, not the hypothesis testing for the second research question or for the second objective. So the sample size for the first one, you estimate it. Estimate the sample size for the second objective, and the one that will give you the maximum sample size. Then you go with that. Okay, so let's look at sample size to estimate impact of any intervention. But this one is individual level randomization. You see here, your outcome is continuous. Okay, you have a continuous outcome. So if you look at this continuous outcome, the critical indicator there is the standard deviation of the outcome measure. Okay, then you see Z subscript 1 minus alpha over 2, the standard normal variate. Alpha is the probability of committing type 1 error. And then Z subscript 1 minus beta. 1 minus beta is just the power of the study. Beta is the probability of you committing type 2 error. And then we see P, the proportion of individual that is randomly assigned to the intervention or the control group. But the minimum detectable effect is critical. What changed? And that one is more policy related. It's not statistics. If I implement this intervention today, let's assume that I want the intervention to reduce, for instance, teenage pregnancy. Okay, so if the prevalence of teenage pregnancy in the community today, let's assume that is 34%, I'm implementing an intervention. I want the intervention to reduce teenage pregnancies, but to reduce teenage pregnancy by how much? If I want the intervention to reduce teenage pregnancy by 4 percentage points, then it means that I'm moving from 34% to 30%. So the difference is 4%. That 4 percentage point is what you call the minimum detectable effect. That 4 percentage point. Okay, so there are two ways. There are cases where your funders will say that, okay, this is the minimum detectable effect that we want to see. Okay, so now they've given you the minimum detectable effect. Then you can use that to estimate the sample size, But there are cases where they will say that, okay, we have money for this. So in other words, they are saying that, okay, you can study, let's say, 2,000 individuals. Okay, what do you think will be the minimum detectable effect? So you are going the other way around. So with the sample size, what now becomes the minimum detectable effect? Remember, I said that the minimum detectable effect is the change between the intervention and the control based on the fact that we implemented an intervention using experimental study design. So that's the minimum detectable effect. That is what we want to see. But remember that this one is for continuous outcome, right? This is for continuous outcome. Okay. Now, there are cases where, based on the previous study, the literature indicates that, well, apart from the intervention that has been implemented, age, education, marital status, socioeconomic status explains, say, 60% of the changes that you see in the outcome. So even though you are implementing an intervention, the estimation of the sample size, you can capture that information. Okay, that is what we call coefficient of variation. So we are asking proportion of the outcome explained by the level 1 covariate. So the age, the education, and whatever, what percentage are they explained? If you have that information, then you can also capture that in the estimation of the sample size. The parameters are not changing, the minimum detectable effect, and then the sample size, they are not changing. And then the standard deviation, they are not changing. Okay. You can note all the questions. So once we get to the question side and you ask specific, you can come into the detail because we are also mindful of the time. Okay, now for binary outcome. So you see the first one was for continuous outcome. So let me go back. So see for continuous outcome, the critical determinant is the standard deviation and then the minimum detectable effect. But the standard normal variate, the Z subscript 1 minus alpha over 2, and then the power of the study, Z subscript 1 minus beta, they are there. Okay, remember 1 minus beta is the power of the study. The beta is the probability of committing type 2 error. So 1 is the probability of you committing type 2 error. Now becomes the power of the study. So the power of the study is captured. The standard normal variance, which is based on the probability of you committing type 1 error, is also captured. The minimum detectable effect is there, but you have the standard deviation there. Okay. Now, for binary outcomes, okay, you see the indicator that we've added now is P star. Okay, so if you look at P star, proportion of the study population that have the outcome of before the implementation of the intervention. Remember, I said that for the teenage pregnancy, based on experimental study design, we wanted, because the teenage pregnancy at baseline was 34%, so your P star is now 34%. You understand? Okay, that is the level of the outcome measure before the implementation of the inter. So at baseline, remember, we are implementing this intervention to reduce teenage pregnancy. You understand? So at baseline, teenage pregnancy was 34%. We want it to come down by, say, 4 percentage points. So then my minimum detectable effect is now 4 percentage points, or 0.04. Okay, at what level? 34%. So the P star is now 0.34. Now, assuming that alpha is 5%, the z subscript 1 minus alpha over 2 will be 1.96. Assuming that type 2 error beta is, say, 20%, then 1 minus beta, which is the power of the study, will now be 0.845. Now, you put it in there to determine your sample size. If they give you the minimum detectable effect, then you can use that to determine the sample size. If they give you the sample size, then you can go back and determine the minimum detectable effect and tell them that if you implement this intervention using this sample size, this is the change that you see, assuming that the intervention is working. Okay, and then the same thing. The only difference here is the fact that this one will adjust for the fact that there are some other factors that will explain the variations in the outcome measure, and that is what we call the coefficient of variation. You know, so if you look at this one and then the other formula, they are the same. The only thing is that here we are incorporating the fact that apart from our intervention, there are several other factors that have been shown in the medical literature that they can also contribute to the outcome. Okay. Now, you see, if you look at the power calculation that we've gone through in the first stage, you know, we use these different estimation techniques. Remember, I've not taken you through power calculation for time to event and all that because of time, you know. But we've gone through estimating power when you have a quantitative continuous outcome, estimating the power or the sample size when your outcome measure is binary, okay? And then you have an exposure, which is the intervention of interest, okay? And then the design is true experimental study design. Now, in clinical trials, because we have different hypothesis testing, okay, the estimation of sample size is still quite similar to what I have shown you, but with some slight deviation in the context of clinical trials, okay? So, and you know, clinical trials is just a study that involves one or more human subjects, okay, where we do prospective random assignment of the individuals into intervention and then the control. Usually people call placebo or whatever name that you can give to that. So placebo is just an inert substance that you give, which has shaped everything like the actual treatment that you are giving out or the therapy that you are giving out. But because it's inert, it's like you drinking water. It has no effect on your system. Now we have types of comparison that we do in RCT. So you see in RCT, like I said, the difference is that we have different hypothesis testing. If you are doing what you call superiority trials, okay, that is to determine whether a new treatment, NT, is more effective than a standard treatment. So if you see ST means standard treatment, more effective than the standard treatment, you can look at it from two different perspectives, okay? One from the statistical point of view, and then from the view of clinical significance, okay? So you see, if I say statistical significance, you can see a change of, say, 5 percentage points, and then your p-value is greater than 0.05. It's telling you that it's not statistically significant. You've seen a change, but that change is not statistically significant. But that same change can have clinical significance. In other words, if maternal mortality is reducing by 5 percentage points, the clinicians will tell you that it makes sense to implement the intervention, invest in that intervention, because it's reducing by 5 percentage points. But statistically, it may not be significant. So that is what we call clinical or social significance, okay? Now, in the context of superiority trials, what we are trying to do is that we are testing this null hypothesis that the new treatment is not more efficacious than the control treatment by either statistically or clinically relevant amount. So if you look at our null hypothesis, New treatment minus standard treatment is equal to 0 versus new treatment minus standard treatment greater than 0. That is statistical superiority. That is our focus. If our focus is on clinical superiority, then what we are testing is that our null hypothesis, the new treatment minus the standard treatment, is equal to delta. What is this delta here? So that is the clinically relevant amount of change that we want to see. So if the clinically relevant amount of change that you want to see is, say, 0.1 kg, then that is the delta. So the difference between the new treatment and then the standard treatment is equal to that 0.1. Okay. Or the difference between the new treatment and the standard treatment is greater than 0.1. So clearly, if you look at this one, it's like a one-tail test. So the delta is what we are referring to as clinically relevant margin. Okay. Which is quite different from the minimum detectable effect, because the minimum detectable effect is just the difference between the outcome measure among those that had the intervention and then those that did not have the intervention. So you see, minimum detectable difference could be, say, 0.2. But the clinicians will tell you that the clinically relevant margin could be 0.1. So there is a difference. So in that case, in the estimation of your sample size, you see that the sample size will change. Okay, so if you are looking at statistical superiority study design, then your sample size just have z subscript 1 minus alpha over 2. You see that for all hypothesis testing, you see z subscript 1 minus beta. If you are not doing hypothesis testing and its estimation in all your sample size, you will not see z subscript 1 minus beta, where is the power of the study. But you only see z subscript 1 minus alpha 1, 2 or z subscript 1 minus alpha, depending on whether your statistical hypothesis testing is a one-tail test or is a two-tail test. Okay, so in the context of statistical superiority study design, your sample size is z subscript 1 minus alpha over 2 plus the power of the study z subscript 1 minus beta divided by the root of the proportion of individuals in the standard treatment minus the the proportion of individuals in the new treatment that had the outcome measure of interest. So you see, and that is a binary outcome. For clinical superiority study design, we have n is equal to 2 times the z subscript 1 minus alpha. So you see, once you see z subscript 1 minus alpha is a one-tail test, plus z subscript 1 minus beta, divided by the minimum detectable effect, which is just the direct change between those that benefited from the intervention and those that did not, minus the clinically relevant margin. That is the delta with subscript naught. For continuous outcome, the same thing. The only difference is that you see we are multiplying our factor by the standard deviation or by the variance if you square the sample standard deviation. And then we have the clinical superiority study design for continuous outcome. So see, the outcome measure is critical. Is your outcome binary or is your outcome continuous? For time to an event, we are not discussing that. I have not added that because of the time. Okay. And then we have equivalence trial to determine whether the new treatment and the standard treatment are equally effective. So you see, this is just a two-tail test. So H naught, your new treatment, minus the standard treatment is equal to delta. Remember, I said that the delta, we are referring to the clinically relevant margin or interval versus the alternative hypothesis of the new treatment minus the standard treatment not equal to delta. In that case, this becomes your sample size. Okay. So you see, depending on the hypothesis, depending on the study design, depending on the power of the study, depending on the probability of you committing type 1 error, depending on the outcome measure, whether it's quantitative continuous, whether it's binary, whether it's a time to an event outcome, it will all inform. Depending on your study objective, are you doing estimation, are you doing hypothesis testing? That will inform you as to how you calculate your sample size. Now, for non-inferiority trials, you have trial designed to show that the new treatment is as effective, but need not to be superior than the standard treatment. The same hypothesis, but what's the difference here? So the sample size will change. So you see here, the sample size is divided by the clinically relevant margin, and then for continuous outcome, the same thing, but here we are multiplying the factor by the sample variance or the standard deviation if you are not squaring that. Okay. So power calculation summary, when power increases, the probability of finding a true impact, if it exists, also increases. The larger the sample size, the smaller the standard error. Remember that that is critical, and then the higher the power. Okay. The standard error has implication on the estimation of your confidence interval. So you say that your estimate is more precise when you have a very small standard error. The smaller the minimum detectable effect, remember that the minimum detectable effect is inversely proportional to your sample size. So the smaller the minimum detectable effect, the larger the sample size. And then when you are designing an intervention, then the intervention is creating clusters. Your focus should be estimating sample size based on the number of clusters, not just the number of individuals within the clusters because of the correlation within the cluster. Okay. And in that case, you also have to adjust for the design effect. And I said that the design effect basically is just 1 plus the intra-cluster correlation coefficient, average cluster size minus 1. But the estimation of the rho, the intra-cluster correlation coefficient, is usually difficult. Because it's difficult, what you do is that you can pick that estimate from previously published, estimate in the medical literature. Okay. So these are some few references. Thank you very much. Thank you.
Okay. Thank you very, very much, Prof. Dwomoh. At some point, I didn't know whether I should say, let's stop here or let's go on. It's been a little over an hour, but it's been very engaging. Thank you very much. This is, I think some people will have information overload, but that is good. If you can stop sharing, we will go to a Q&A session briefly, but let me just quickly share some information on COBREG. You have to... okay, so Prof. Dwomoh has gotten up. Probably he has to... Prof. Dwomoh, are you available for a few more minutes? Is it possible?
Yes, I'm available.
Okay, so I want to do just 3 minutes of introducing the association and just a bit of information. Then we go to the Q&A very briefly. Okay, so I'll take just a few minutes to tell everyone on. I'm not sure if everyone is a member of COBREG, so just a little information about COBREG and what we do, and then we'll come back to our Q&A session. So COBREG is basically the Convention of Biomedical Research Ghana. It is an NGO that is registered in Ghana and works very closely with its mother organization, which is based in North America, that is known as the Ghana Biomed Research Network. So membership is open to a wide range of researchers, as you can see there, clinicians, biomedical scientists, bioengineers, laboratory technicians, public health specialists, and any other persons who are committed to advancing biomedicine and promoting health in Ghana and the West Africa sub-region, as well as the continent at large. Now, these are reasons why we would want to invite you to be part of this family. We do organize a lot of programs throughout the year. We normally have an annual scientific conference. We've not been able to do that this year, but we are gearing to get that done next year. So if you are a member for these conferences and workshops, then you get a discounted rate to attend. We also sort of help you to access very high quality scientific publications. There are opportunities for networking as we will have after this. We do organize career development sessions. We do organize information sessions just like we're having now, just to update our knowledge in certain areas. And then there are also internship opportunities that come up here and there that you can take advantage of. And then, of course, you have the voting rights and to also be able to contribute to the leadership of the organization at our annual general meetings. And then also become a member of other global initiatives that would advance biomedical sciences. So all these are advantages of becoming a member of this August body. And we invite anybody who is on now and not a member to take advantage and become a member. Now, to be a member in good standing, this is what you need to do. After registration, we have our dues for professionals, including postdocs, set at 120 cedis. That is for an entire year. That is almost just like 10 cedis a month. And then we have the rate for students, which is 50 cedis. And all these can be paid via our MTN Momo account. The details are being displayed. Or you can also make your dues payment directly to bank accounts, and we are displaying the account details on there. We also do receive donations. If anyone, philanthropists that want to donate for the advancement of what you're doing, we also accept those through the same channels. And these are normally used to promote our activities, the in-person workshops especially, and also the conferences that we organize. We need funds to support them. So this is a bit of information on the association, and we're doing this now because normally this information is shared at our annual scientific conference, but because we are not having it this year, we thought it would be good to just remind members that the association is still in need of the resources that it needs to run. So please, if you have not made your dues payment, kindly do that for us so that we can keep afloat and get things done for you as we have consistently done over the year. So this is information. The website, which I didn't put on the slide, is www.cobreg.com. So COBREG, COBREG.com. That is the website address. And if you go there, you get access to all our past activities. You get access to know more about the organization and what we do and what we have achieved in the past, and any other information that you need to have about the organization. So thank you very much. If anybody needs any further information, you can always reach out to us by email, or you can leave messages on the website for us, and we will respond promptly. Thank you very much. So we come back to our webinar, and this is now time for us to take some questions. We can have people ask questions if you have any. There are also some questions in the Q&A chat that we'll be reading. So Prof. Dwomoh, if you are ready, we can begin that session. I will probably, if there is any question anyone wants to ask and want to unmute themselves and ask that question. Otherwise, I can start from the Q&A. So we have the first question from Nana Pipra that says, Prof. Dwomoh, are you available?
Yes, I'm here.
Okay, all right. So the first question says, is p-value the only way to determine significance? I'm guessing statistical significance. So we take them one by one.
So you can also use the confidence interval to determine statistical significance, So that is one. The other thing is, if you are not interested in statistical significance, you can also look at it from the perspective of clinical or social significance. For instance, and I even said that as part of the presentation, you can implement an intervention, and then the intervention will cause a change of, say, 5 percentage points in the outcome. But that 5 percentage point may not be statistically significant. That is when you compare your p-values to the probability of you committing type 1 error. You end up saying that, you cannot reject the null hypothesis because you do not have enough statistical evidence to do that. That is statistical significance. But in the context of clinical trials, or in the context of you looking at it from the perspective of clinical significance or social significance, if the 5 percentage points, which is the effect size, is big enough, then you can say that, it has clinical relevance or it has social relevance. So that's the difference between the two.
Okay. All right. Thank you very much. Please, if the answer is provided and you have you need further clarity, just type it in there. We'll read it out. But the next question says, please, how do you go about your sample size estimation when you are using a cross-sectional study? Let's say I'm working on a project that is focused on prevalence and it is a cross-sectional study. How do I go about it that's my, how do I go about estimating my sample size?
Okay. So you see, for the cross-sectional study, let's assume that the only research question is what is the prevalence of whatever in the population. In that case, what you need is just the standard normal variate, the z subscript 1 minus alpha over 2, and then the prevalence from a previous study, you know. So the only thing is the z subscript 1 minus alpha over 2 multiplied by the prevalence, 1 minus the prevalence, divided by the margin of error squared. And then you can also multiply that by the non-response rate, which is the denominator y squared with the margin of error squared times 1 minus nr, the non-response rate. So in the context of cross-sectional study, what you need, if it's just estimation of the prevalence, is one, the prevalence from the previous study. If you don't know, you can assume 50% because 50%, right? Because 50% will give you the maximum variance, you know, the P into 1 minus P at the numerator. Okay, yeah. And then the standard normal variate, the Z subscript 1 minus alpha over 2. You also need that. And then the margin of error, which is at the denominator. Okay, whether the margin of error 5%, 10%, 1%. Remember, the margin of error also has implication on the size of the sample. Okay, the smaller the margin of error, the larger your sample size. So if it's only estimation of prevalence, you need prevalence from previous study. If you don't know, use 50%, the standard normal variate, the margin of error. Those are the critical needs. But if it's a cross-sectional study from a complex survey design, then you have to adjust your sample size with the design effect. So the design effect multiplied by the factor when you assume that the individuals will be generated through individual random sampling technique. That's all.
Okay. That is very, very detailed. Thank you. So I have Miriam Adupo's hand up. Miriam, if you can ask your question, then I'll come back to the Q&A.
Okay. Thank you very much, Prof. Dwomoh. Okay, so my question, following up with a question on the cross-sectional design, we are just talking about the sample size estimation, but I don't know if it's permitted for me to ask something related to the analysis. So let's say that you have carried out the calculation and you had 176. So in making room for non-response rate of 10%, you have, let's say, 188 from your calculation. And then the final data inputs you have received for your analysis, you had 184. So from that, maybe you could calculate, you know that it's less than your sample size you estimated after the non-response rate. Now, in your analysis, you only have two variables that are significant. All other things, let's say age, all other factors you considered are not significant. It's just to maybe marital status and diet. And because of the sample size you have, it looks like your regression model, every other thing, it's not, I don't know what term to use, but it's not working. I don't know how to put it anyway, yes. So I'd like to find out, how do you approach such analysis in your association, you just realize that they are just too significant. How do you approach it in terms of your write-up and all? Do you have to increase your sample size? Because I'm asking for myself because I had to roll out my survey in hope that I'll get more people. And that is what I even have as of now. So what do I do from here?
Yes, so there's two fundamental problems here.
Okay.
You know, one, when you were estimating your sample size, you assume that you were only going to do prevalence estimation, not to fit regression models in the first place. Do you get it? You see, it's cross-sectional. Okay. And maybe in the estimation of your sample size, you say, oh, z squared subscript 1 minus alpha over 2p into 1 minus p divided by the margin of error multiplied by 1 minus the non-response rate. And then you estimated your sample size. You know, what you were technically doing was estimating sample size for just determining prevalence, not to determine factors influencing an outcome in fitting a regression model. Do you get it?
Okay.
So your sample size technically is underpowered to address the other research objectives. You get my point now? When you are fitting the regression model. So it could be that it's not that the variables are not statistically significant. It's because your study is underpowered. So you do not have enough sample size to see that difference. And that is why you are saying that. Okay. One of the ways that you can mitigate that effect is to use inferential method for least absolute shrinkage and selection operator. We use it for high dimensional data. We call it lasso. Okay, not lasso for prediction. I have to be clear. Not lasso for inference. So you can use lasso when you have high dimensional data, where your sample size is small relative to the number of variables that you have in the data set. So that is one way that you can look at it. But it was a fundamental flaw in the design. You know, if you had known that you were going to fit regression models, you should have adjusted for that in the estimation of the sample size in the first place. Because for the cross-sectional study, you estimated the sample size, assuming that you are only going to determine prevalence. One other thing that you can do is just concentrate more on the bivariate analysis. And then you can highlight the limitation associated with only conducting bivariate analysis. Over.
Yes, thank you very much, Mariam. I think that answers your question.
Yes, please.
Yes, and this is exactly one of the motivations for this when people just base their sample size estimation on prevalence when their actual outcomes are very different. Thank you very much, Prof. Dwomoh, for the clarity. So I'll go on to the next question. It says, in what context of the discussion can one apply online sample size estimators like GPower?
Yes, so you see, whether it's online, whether you are using a software, it's just the statistical methods, getting your parameters right. Because G-power, for instance, is usually used when you are fitting multivariable models, where you want to quantify effect of several independent variables on your outcome. So in that case, it's not straightforward. You know, in the context of experimental design, you have just one exposure. And because of the random assignment of the individuals into intervention and control, we say that there's no systematic difference. So all the other independent variables will not influence your outcome measure of interest because the randomization will take care of that. And that's why estimation of sample size based on experimental study design is just straightforward. Okay. But if the design, for instance, is even not from experimental, but you want to look at how several variables explain the variations in your outcome measure of interest, then in that case, you use more, what do you call it? Sampling variability techniques like G-power to determine the sample size. So you see the G-power is not based on sample size. It's based on, it's typical to machine learning algorithm. Okay, so that it will give you an appropriate sample size based on the number of independent variables that you want to study. That is what we do. Yeah.
Okay. All right. Okay, I see Ebenezer Ukansi's hand up. If you can ask a question. Ebenezer, can you unmute and ask your question? Otherwise,
yeah, thank you, sir.
Okay, all right, good. Let's go on.
Okay, so I was the one who asked the first question about the cross-sectional study and the prevalence in the question and answer column. Yeah.
Okay.
So let's say going forward, your sample size is based on, let's say, only prevalence. And then you want to test for association during your analysis and other stuff. Can you still go ahead with the same sample size?
Yes,
let's say I'm working on semen, and let's say I'm testing, let's say, the association between, let's say, the sample taking method and then, let's say, age.
Okay, so let me explain that once again.
Okay.
You can run any statistical analysis once you have your data. Okay. But as to whether your study is powered enough, in other words, as to whether your sample size is enough, is powered enough to see a significant effect of your exposure of interest on the outcome measure is another thing. Because your sample size, you design it to estimate prevalence, you may not be certain, you may not know whether the sample size that you have now, okay, is powered enough to see a significant effect if you want to do association studies. That is where the difficulty is. Do you get it? So it has limitations. So once you run that analysis and you are not seeing a significant effect of the exposure on the outcome, then you don't conclude that, oh, there is no relationship and whatever. You draw that, but as part of the limitation, you say that your study was not actually powered to test that hypothesis. Do you get it? So that you put the reader in context. Over.
Okay.
Yeah. Okay. So, Ebenezer, maybe what I can also add to that is the fact that this is why you need to determine or include doing all these things right from the beginning of your study and not waiting till the end to now determine or decide that now I want to do this additional analysis.
Okay.
All that should be planned right from the beginning. Yeah.
Okay. Okay.
Okay. I see 2 hands up. Let me call. Miriam came up first, but Miriam has asked 1 question. So Miriam, hold on for me. Let's take Kasim Abdullahi.
Yes, thank you very much, Prof, for this very, very educative presentation. You've already addressed 2 of my questions. I have 3. The one I would like to read it out. And the question is, in cross-sectional studies, such as determining prevalence, so can one do comparison? And I think this is just it's related to the question that was just answered. Say you want to compare the prevalence between male, or whether there's a difference between male and female, even though that probably was not intended when you were planning the design. Thank you.
Yes. So see, you only use z-test for comparing difference in proportion. Do you get it? Z-test for comparing difference in proportion. So you have among males, do you get it? You said males and females. Among males, what proportion had the outcome? Among females, what proportion had the outcome? Then the difference. So that is z-test for comparing difference in proportion. So you can test that. So your null hypothesis is that, there is no statistical significant difference in the outcome measure between males and females. Alternative, there is statistical significant difference in the outcome measure between males and females. So using the z-test for comparing difference in proportion, you can determine that. But the problem is, if you don't see a significant difference, it could be that it was because your study was underpowered. Do you get it? Actually, in the estimation of the sample size, you could have used sample size estimation for comparing difference in proportion. Do you get it?
Okay.
So let's assume that if you knew that you were going to do this, you have 2 research questions. One is, what is the prevalence of the outcome measure? Okay, then that is your research question 1. Your research question 2 is there any statistical significant difference in the prevalence of the outcome measure between males and that of females? Question mark. So you are designing the studies cross-sectional. So you do sample size estimation for the prevalence, put the figure down, let's say it's 400. You do sample size estimation for comparing difference in proportion. That is the second objective. Let's assume that is 580. Now you go with the 580 because it's giving you the maximum sample size. In that case, you are certain that once you have your cross-sectional study, you can still go ahead and do or use the z-test for comparing difference in proportion to test that hypothesis. Do you get it?
Yeah.
Do you get it now?
Yeah.
But because you did not do that, you can still analyze because you have the data. But you have to be very careful when it comes to the conclusion because your study may not be powered enough to draw that conclusion. Over.
All right, thank you. Please, final one. And that has to do with the clinical significance or relevance and also statistical significance. If your intention is to find statistical significance, but what you got is not significant statistically, but you think the difference that you are seeing is of clinical relevance, can you still report it as such?
Yes, we report clinical significance all the time. Okay. So see, when we report clinical significance, it doesn't mean that you are not adding the p-values. Do you get it?
Yeah.
You are still adding the p-values. It's not significant. But then the argument is that even though your p-value is not significant, the difference between the exposure, okay, and then your control group is quite okay based on whatever you are doing. And so we call it plausibility argument. You make that argument along the line that, well, I ran this analysis, I realized that the intervention is not statistically significant. But looking at the effect size, the intervention reduced maternal deaths by 7 percentage points, which makes sense. So go ahead and invest in it because it makes clinical sense. Once you invest in this and you have 100 mothers who are going to deliver in a recommended health facility, 7 of them will be saved. So your argument is now on the clinical significance, not on the statistical significance. So you have to report, including the p-values, and then make arguments for the clinical significance. Over.
Thank you.
Thank you. So we have a very limited time now. So Miriam, your hand has been up for a while. You ask a question. I'll go to the Q&A and come back to the second hand up, Ebenezer again. But Miriam, you can go now.
Okay. Yes, please. Okay. So I'm actually making a follow-up to what I asked the first time. So the study, let's say,
keep it very brief, straight to the point.
Yes, please. Yes, please. So the study is on stress. Like I've had the initial explanation made. So there was the quantitative side, and then there was, let's say, a focus group discussion. In the discussion, which is the qualitative side, it's came out that people are stressed. But then in the study, it didn't show. So it's been explained that it may be underpowered. But in this case, can I talk about social significance? Because that has come up in the discussion. Can I refer to that?
Yes.
In my
you see, for social or clinical significance, right? You make argument for that. It doesn't mean that you're not reporting on your p-values and all that. So the most important thing is that make argument for that. But you see, in your case, you also have to highlight it in your limitation.
Yes,
that
please.
The study may be underpowered because in the estimation of the sample size, you did not have the intention to test that hypothesis. Do you get it? So you have to highlight that as part of the limitation as well. Yes.
Yes.
Okay.
Please.
Thank you very much, Miriam. Yes. So I'll go back to Ebenezer, I'll come back to you. Please hold on for me. So please, can a cluster randomized trial be a clinical trial? That's the question there. I think yes. I think that's
yes,
a very short answer.
So it depends. So let's assume that I'm implementing the intervention at the facility level. So that is cluster randomized trial. And then I have specific cancer patients within that facility, and they are all going to benefit from that intervention. So even though the intervention is at that level, I'm still giving whatever, if it's medication and whatever, to all those who are coming to that particular facility. Usually it happens when you are dealing with what we call integrated intervention. You have some intervention that you want to use it to improve quality of, say, cancer patients. One is about the drug that you are giving. And then the other intervention that you are giving, it has to do with training healthcare workers at the facility level. So see, once you are doing the clinical trial at the individual level and you are giving the drugs, for those same people in that facility, you are training the healthcare workers. So it's an integrated intervention. So it's cluster randomized with a bit of individual level randomization because you are giving the treatment to individuals within that facility. And at the same time, because it's integrated, you are also training these healthcare workers on how to improve quality of care of cancer patients. So it happens. But then when you are doing your write-up, you have to be clear as to the kind of intervention, at what level are you implementing this integrated intervention, which portion is only going for the individuals that you are studying, and which portion is going for the people who work at the facility level. And that's what I'm saying, that it can happen, but it depends. And usually it has to do with the integrated level of intervention. Those are the individual, and then those are the facility that you are training. Over.
Okay, thank you very much. I'll ask one more question from the window and I come back to those whose hands are up. So the next question says, does the proportion of P in estimating the sample size and giving MDE follow a certain distribution, or how is it estimated? So I've asked it in a way. What the person actually typed is, my question is, the proportion P in estimating the sample size and giving MDE, does it follow a certain distribution, or how is it estimated? You are muted.
Sorry.
Yes.
So is the person asking about the minimum detectable effect? So my question is, the proportion P in estimating sample size N giving the minimum follow? Yes. So if it's just the P, it's just a binomial distribution. It's a binary outcome. So it's a binomial distribution. It follows that distribution. So it's like you are comparing binomial distribution in two distinct populations. The first distinct population is those with the intervention or the treatment, and then the other one is the control. So difference in proportion. Do you get it? So the distribution is just the difference in proportion that you are comparing. But within each population, is just the binomial distribution. Yeah.
Okay, good. Ebenezer, if you can ask a question now.
Okay, sir, a quick one. So let's say I do my sample size estimation and then I got about 178. And then along the line, I went to the field, did everything I could, and my project time is also limited. And I got a 10 out around, let's say, 100, which is not up to the sample size I calculated initially. Is there anything I could do about that?
Of course. You can't do anything about your sample size. The only thing you can do is to go back to the population and continue with your sample size, your data collection. That is the only thing you can do technically. But, the first question is, did you adjust for non-response in the estimation of your sample size? Let's assume that you adjusted for non-response and you added 78, I'm assuming. It means that you don't have any problem because your minimum sample size without the non-response is 100. In other words, you can work with 100. But if in the estimation of the sample size, you only estimated your minimum sample size to be 178 without adjusting for non-response, then it means that your study is underpowered, okay? Because instead of 178, you are now working with 100. You can't do anything. What you have to do is to highlight that as part of the limitations of the study. Do you get it?
Okay. Thank you, sir.
Okay, so we go on to Rebecca. Rebecca, are you on? Otherwise, Isaac, you can go and we take Rebecca later.
Okay, thank you very much. As Prof was talking, he made mention of the minimum detectable effect being inversely proportional to the sample size. And I want to ask that if the sample size is too small, how can the detection, like if you want to get your effect, you want to observe your effect, how can that have an effect on the least observation you are going to make?
Yeah, so what I said was that the minimum detectable effect is inversely proportional to your sample size. In other words, the smaller the minimum detectable effect, or the smallest change that you want to see between the intervention and then the control, the larger the sample size that you need to see that small effect. Of course, if the change is so obvious, if the effect of the intervention, the treatment, or whatever exposure is so obvious, then you don't need a huge number of individuals to see that effect. If you sample 2020, you see that because it's huge. You understand? So that is the implication there. If the effect is so small, then you need huge number of people to see that small effect. But if the effect is obvious between the two groups, then you need a smaller number to see that. That is the implication.
Okay, so I'll take two quick questions from the Q&A and then we'll come back here. So the next question I have here on says, I am currently conducting a study which is both case control and cross-sectional. How do I increase the sample size? I'm not sure if you meant how do you estimate or increase, but it says, how do I increase the sample size?
Yes, so if it's about the estimation, in the estimation of sample size for case control study, one, you need the proportion of controls who are exposed. You need that. You also need the odds ratio from previous study. You know, for case control study design, the estimate is odds ratio. So if you have an exposure and then the outcome, which is case control, from the previous study, what was the odds ratio? Okay, so the odds of having the outcome, if you're exposed compared to the odds of having the outcome, if you are not exposed. So you also need the odds ratio in the estimation of the samples. The other thing that you need, if it's just about estimating the odds ratio, you know, for case control study, you can estimate odds ratio. But if it's about testing hypothesis about that odds ratio figure based on the case control study, then you also need the power of the study, that the Z subscript 1 minus beta. And then you also need the probability of you committing type 1 error, or in this case, the standard normal variance, with the Z subscript 1 minus alpha over. And they all should be there in the estimation of the sample size for the case control study. So the proportion of controls exposed is critical. Yes. Over.
Now, what if there is no previous study for you to get an odds ratio to start with?
So you do pilot. So you do pilot, or you make educative guess. Or the other thing that you can do is based on expert knowledge. You can say that, okay, the odds will be like 2 times or 1.5. And then the last thing that you have to take into account has to do with the budget. Do you get it? Has to do with the budget, because the odds ratio, also the estimation of the samples are based on case control. The fact that you do not know the odds ratio has budget implications. So if you are assuming, you're also looking at it relative to the budget. So if you say an odds ratio of 1.5 and you are getting 2,000 and you can't work with 2,000, then of course you are forced to use a different odds ratio that will bring the sample size. So you also have to take into account the budget consideration in that context.
Okay, there is an easy question here, so let me ask, then I'll come back to those with their hands up. So the next one says the R squared in the sample size determination, is it coefficient of determination or coefficient of variation?
So it's the same thing. You know, it depends on the interpretation. Do you get it? You know, technically, if you're looking at coefficient of variation, it's just the mean divided by the standard deviation times 100. You know, coefficient of variation. And then the R-square, which is coefficient of determination. If it's just two variables, it's just the square of the coefficient of correlation. You understand? But in the interpretation, is the same thing. You know, the coefficient of determination is just the proportion of the variance in the outcome that can be explained by the independent variables. That's the coefficient of determination, which is similar to the coefficient of variation in this case. Okay. What proportion of variation in the outcome measure could be explained by the independent variables under consideration? That's all.
Okay. So let me move on quickly. Rebecca, are you back, or we can move on? Rebecca. Okay, Joseph, you can ask your question.
Yeah, thank you, Prof. This is Amechi. Thank you for the presentation. Yeah, so I wanted to ask about this case control designs. In most cases, your exposure is binary or categorical, and your outcome is also categorical, or the case and controls. Is there any provision for cases where, or situations where the exposure itself is on a continuous spectrum, on a spectrum? So the exposure is how much of cigarette you have smoked, or how much of pollutants you have received in the community. And the cases are those who have cancer, the controls are those who don't have cancer. Is there any provision like that?
Yes. So the only thing is you can just even change that. You can swap that. If the exposure is continuous and then your outcome is binary, you can even swap that. Do you get it? But two ways to address that. You can even use sample size estimation for comparing difference in means to do that. So in that case, you are swapping the exposure to be a quantitative continuous outcome. So now your outcome is now quantitative continuous, but it's technically the exposure. And then your exposure now becomes the binary outcome, or a categorical variable with only two levels of the factor. So you can even use sample size for comparing difference in means. Do you get it? And depending on the design, you can just adjust for that and use that to estimate the sample size. Another thing that you can do is that you can use Jane ladder, that is just simulation approach, because in that case, you are still going to treat your outcome as binary and treat the exposure quantitative continuous. Okay, the exposure will still be quantitative continuous, and then just simulate to see at what point on the continuous spectrum will you get the highest sample size and do that. So you can go by either using by swapping it and using sample size for comparing difference in means. Or you can use the G power when you fit a logistic regression model, because your outcome is binary and then the exposure is still quantitative continuous. And then use the G power to determine at what point of the continuous spectrum, based on the outcome measure of interest, will you get the maximum sample size. That's all.
Okay. So we'll take the last question from the audience, and then I'll try and cover what is in the Q&A. So Isaac, you have the last question.
Yes, please. Thank you for giving me this opportunity. Prof made mention of John Henry effects, and I want to ask, after maybe we have committed capital into the study and you got into a stage whereby you cannot reverse it, is there a way that we can correct that mistake that may occur?
We have two different estimates. So you see, in the context of evaluation, you have intention to treat. You know, intention to treat estimates are always biased, but it's very good because that is what happens in real life. Like I said, you can only offer an intervention, but you can't force anybody to take up your intervention. Do you get it? Okay.
Yes.
So because there is contamination, when you are estimating the impact of the intervention, instead of doing treatment on the treated estimate, because that one you have to restrict your analysis to only those that actually benefited from the intervention, then you compare them to the peer controls. But because of the contamination, you will not generate treatment on the treated estimate. What you generate is what you call intention to treat. So even though you know that people violated the rule, you still assume that they are in the intervention group. And those who in the control but benefited, you still assume that they are in the control group. Because in the intervention, some will also not benefit, even though they were assigned the intervention. But you still assume that, oh, they benefited, all of them benefited. And then in the control too, even though some of them benefited, you still assume that none of them benefited from the intervention. And that is what you call the intention to treat analysis. So you report that estimate. Do you get it? One is biased, but it reflects what happens in real life. Over.
Okay,
Okay,
thank you very much.
so
So there are a few questions that I think are quite relevant. So let me quickly run through them. So the first one says, basically saying that their students, they don't conduct a lot of trials, but the question in there is how, or maybe nonetheless, it says sample sizes are practically determined on the grounds by cost, time, etc. How can sample inadequacy here be accounted for and justified? He's talking about they are doing studies, basic studies as students. The key things are time and cost. So is there a way to justify sample inadequacy
Yes,
in an instance like that?
as when I was doing the presentation, I made it clear that we have what we call power calculation and power analysis. Power calculation is the science and is based on the statistical formula and all that. So, the standard deviation of the outcome measure, the type 1 error, the power of the study, the margin of error. If it's a complex survey or whatever, the design effect, then you estimate. That is the number. But then we have what we call power analysis. So power analysis, you have to factor in budget. So the justification is the budget. The justification is the fact that there is a conflict there. There is an armed conflict there, so I cannot go there. So the fact that my sample size is supposed to cover Boko and there's an armed conflict in Boko, I don't have to go there. So automatically the sample size will reduce. So your justification has to do with the fact that this is my sample size. I'm supposed to do this community. I'm unable to go there because there's an armed conflict and it's allowed. Do you get it? So the justification, if you're doing power analysis, will be based on the reasons that you provide as to why you are going below expected number of individuals to be interviewed. That's all.
Okay. So quickly, the next one says, do we calculate the non-response rate? And if yes, how? I'm guessing, judging from calculating a response rate, is the non-response then just a difference?
The non-response rate is based on your previous experience with the study, based on what others have reported. Let's assume that you implemented an intervention, you are giving some drugs out, and then you want to follow them for 2 years. But the same design has been implemented in Nigeria, the same drug. They follow these people up over a period of time. And from their study, they indicated that attrition rate was, say, 16 or 17%. Of course, they've given you a clue as to what you should expect when it comes to attrition. So that is where you pick that estimate from. There are cases where no study has been conducted, but you still anticipate that because it's a follow-up study, people will be lost to follow-up. That one will be based on the budget, because you cannot say that, because people will be lost to follow-up, so you want to increase your sample size by 50%. It will depend on your budget. So what you do is that you look out for a more conservative estimate based on the cost, based on your budget, and say, I'll do 15, I'll do 10%. That is how you do that. But we don't estimate it. It's based on previous experience. It's based on the medical literature on similar study. And then it's also based on your budget.
Okay. So the next one, I think it's an obvious answer. It says you are working on archived samples and you've calculated your sample size and it's small, but you have a lot of samples. Do you just add on or you go by your sample size?
What do you mean by archived samples? Like secondary data?
Yeah, so like you did, you've archived biological samples. You are keeping them in storage, and that is what you are going to base your study on. You are taking your samples from previously collected samples to do new work.
Of course, but if the data set is there, you see, the larger the sample size, the more powered your study is. So we want more samples to work. So once you have a sample, we don't work with a smaller. If you have, say, 10,000 individuals, what is the essence? They are there. The data is existent. It's there. So what is the essence of you reducing it to 7,000? You work with
so he's talking about in the context where they have done a sample size calculation and say the sample size says you need 1,000, but they have 10,000. Should they go by the 1,000 that the sample size mentioned, or they can use all the 10,000?
Yes. See, we sample size estimation one, because you're also looking at the cost. We don't want a situation where you want to oversample and it will have cost implication. And we don't want a situation where you want to undersample and then your study will be underpowered. Do you get it? That is the essence of doing sample size estimation. So if you do proper sample size estimation, it's saying that you need 1,000. You only work with the 1,000 because doing the 10,000 will only add additional cost. Do you get it? Unless perhaps the sample size estimation was not done correctly. But if it's done well, that is the essence of sample size estimation. One is to minimize cost, and two, to make sure that your study is powered enough. You understand? So if you do your sample size and it's like 1,500, you don't go and say that, okay, I'll do 20,000, because the only thing you are adding is cost. You are not adding anything to it. You understand? So the sample size estimation, one, we do because we don't want our study to be underpowered, smaller sample size based compared to the recommended, or you have too many sample size based on what you require. And that is the essence of we doing sample size estimation.
Okay. I don't know if you covered this one, but there's a question here that's asking about how you calculate sample size for a longitudinal study.
Yes, it's two ways. If the longitudinal study is just before and after, that is PET. You can use sample size estimation for PET test. In that case, the only one important variable that you need is what we call the correlation coefficient. You need that to estimate that. So you can do sample size for that. But if you are going to follow them over a period of time, of course, you have to also factor in attrition rate. If it's not just about estimation, so it's not like just prospective cohort study where you are following people, but you're also doing hypothesis testing. Then you also have to factor in power of the study. Do you get it? And then the probability of you committing type 1 error or the standard normal varies. You have to factor in that as well.
Okay, thank you very much. I think the very final question is whether the slides will be available, but we will talk about that in the back. But also with Prof. Dwomoh's permission, we will also be hosting this on our website. We have all our webinars, the recordings of all our webinars on the website. So if you need to go over this again, you can access it from there. So I think on this note, which is a very good one, we will bring this to an end. If there are any other questions, please, you can send an email or try to reach us, and we'll try and get Prof. Dwomoh as much as he has time to respond to them for us. But this has been a very good session. Prof, thank you very much. I have learned a lot from this myself, and I think it is something that we all need in order to plan very well-powered studies, to plan very good studies and have outcomes that will be impactful and can be picked up for policy. So thank you very much, Prof. Dwomoh, and thank you to the audience as well for making it to this webinar. I think at the height I saw something around 160 or 170 people. That is very good. Our next webinar will be the first week in November, and as you've seen, we are planning something very good and a good surprise for all of you. So when we announce that, please register and join that next webinar, and it will be one that will benefit you greatly. So thank you, George, Nana Pipra, for doing the background work for us in terms of the Zoom link that we've used to do this. While we are just on here speaking, some people have been working probably in the last 1 to 2 months trying to set this all up. So thank you all very much. And I would wish you a good afternoon, good morning, good evening, wherever you are. And we'll meet back here in the early part of November for the next webinar. Have a good day. And remember, we are waiting to receive your dues as members of COBREG. And also, you can go to the website, like I said, www.cobreg.com, where you can get more information on the organization and what we stand for and what we do. So thank you and good afternoon to all. Bye-bye.